So I don't really need to introduce either of you. I don't know, does everybody know Michael Guerriere? And Michael's mainstay and coach for many years, I would dare say, Denis Protti from the West, from Victoria. And you're not really retired, Denis.
Not totally, yes.
No. So we're really pleased to have you, Denis Protti and Michael Guerriere.
Are you going to drive or shall I?
So you can start, yeah.
Okay.
All right.
We're making this up as we go along.
Yeah.
I'm going to start at the bottom of the slide. If we can make this into an interactive conversation this morning, it'll be more fun. Especially since I see a lot of people in the audience that I've argued with in the past. I think it'll be more instructive for all of us. We put this point at the bottom to suggest that we'd be quite happy to be interrupted. We debated whether we should put demonstrations encouraged, but we decided to stop short of demonstrations.
Fortunately, there are no tomatoes out there, so.
Yeah, that's why we do these at breakfast as opposed to any other meal. So these are some of the topics we wanted to touch on, and hopefully have a bit of a dialogue on. So talk a little bit about the sustainability story as the backdrop for virtually everything that we're now facing in healthcare. Some of the opportunities for bending the curve, I think there's some actual evidence and some encouraging results from different organizations that we want to try to point to. How sustainability relates to health information technology, and in particular we want to talk about primary care and some of the results in primary care from around the world that I think we can take example from. And then we'll end with just a summary of thoughts on what it takes to get value from an IT investment. I think we've labored under a little bit of a false belief that if we build a lot of information technology platforms in healthcare, that good results will miraculously come out of that. And in fact, more and more we're seeing evidence that that isn't the case, and that there are a bunch of other things that have to go with the technology investment to actually achieve value that's of meaning to patients, that's of meaning to payers, etc. So I'll look at the next couple of slides and then hand over to Denis. This is a bit of a daunting slide. This is data that comes from Statistics Canada on real GDP growth, going back to
Health expenditures.
Oh, I'm going to get to the GDP growth. Okay. Health expenditures. That's why Denis is here, to actually keep me talking about the right slide. Now, this is real health expenditures. I always had debates with the people at CIHI about whether nominal or real expenditure growth was the thing that we should be reporting on. And this is often a source of some confusion among the public. So these are inflation-adjusted healthcare expenditures, and this is the growth rate year over year, going back to 1989. And you see this, many of us have memories of the 1990s experiment with suppressing expenditure growth in healthcare. And many of us have further memories of the rebound that occurred after that, much of it around a wait times theme that emerged more here. But you can see that we did, in fact, suppress growth in healthcare expenditures, real growth after inflation, to below 1%. So we're now getting to a point where you know, we're back to talking about very low rates of growth. Just to put it into perspective, the Ontario budget's projections in terms of growth in healthcare expenditures on a real chart like this would be 0 or potentially below 0, because they're talking about, I think it was 2.1%. Somebody correct me if it was, I think it was 2.1 or 2.3, something like that. So given current inflation, that would be a 0 rate of growth, which of course we've never actually achieved. We got close for a couple of years, but one of the lessons learned over here is that if you reduce growth by suppressing wage increases, artificially, not permanently, that you follow with a catch-up period. And so, you know, over here, we're really talking about doing the same thing as suppressing wage growth. We're in the, Graham Scott was just talking to me that, you know, he's in the middle of negotiating with the Ontario Medical Association for the government. I mean, we're into, you know, an austerity period. People don't expect that to be permanent. So this is going to be very difficult without some major structural change in the way the healthcare system operates. So let me add to the health expenditures information the GDP growth information, so that in each year you can compare the growth in the economy to the growth in health expenditures. And you can see the blue bars now are the GDP that's been added. You can see the recession, the 1990-91 recession, where, you know, we had a significant reduction in GDP, transient. And you see a reaction over time of health expenditures being suppressed. You also see a very fast economic springback of the economy in the subsequent years. I mean, we had a 5%, almost 5% year-over-year growth in 1994, and, you know, some pretty significant growth rates. And then, of course, into the late 90s, I mean, we had some pretty big numbers. So very interesting to look at this and to look at this and to look at the green bars and to look at these green bars and, you know, the reaction that's now coming through as we try to deal with deficits and try to suppress healthcare expenditures. So the Ontario budget at least has us flatlining. Of course, other provinces have somewhat different circumstances. The thing that I think I'd like to also point out is 2 other factors to just keep in the back of your mind as we're thinking about this. One is that we do not expect, you know, growth rates in the 3+% range for GDP in the economy in the near future. Nobody's forecasting those kinds of growth rates. Those growth rates supported big increases in healthcare expenditures, and we're not expecting the same spring back here. Could happen, but right now there's a lot of factors that mitigate against that. You remember what the Canadian dollar was back here compared to what it is now. And the other thing to point out is that back here, healthcare expenditures were about 35% of program spending in provinces. And here, they're about 45% of program spending in provinces. So our leeway is significantly different. So we're going into a really challenging period for the industry. Dennis.
Okay. Thank you, Michael. All right, this is just to, I guess, make us feel a little bit more assured that we're not alone, and that the concern about sustainability is a global concern. I was just at an OECD meeting in Paris in January, and sustainability wasn't on the agenda. It was nowhere near on the agenda. But it was amazing that almost every country represented it somehow, at some time during the course of the meeting, mentioned their concerns about sustainability of their healthcare systems. And Michael just mentioned that it's now 45% in Ontario. If you read Will Falk's paper on fiscal accountability in healthcare. He said if we continue the projections the way it's going, by 2030, Ontario's healthcare budget will be 80% of the provincial budget. So clearly, that's something that we cannot continue. And there's a number of authors, which I'm sure you've read, express concerns about sustainability of the healthcare system, although, interestingly enough, not all. Some consider it's not an issue. But this just shows where the growth rate is across the world. And of course, in some ways, we're looking better than others, the OECD average. But it gives us a sense. Now, this just came out, and we debated whether to include this because it's American. We did for a number of reasons. One, we did it because it's work from Donald Berwick, and it was highly respected, the former head of the CMS, the Medicaid, Medicare services in the United States, probably the best candidate to have run that organization, but unfortunately, due to the political agenda down in the United States, the Republicans didn't like his way of thinking, and they forced him out. So he just produced this data, and we looked at it, and we said that's very interesting in terms of maybe there's some answers in here or some suggestions on how to bend the cost curve. And I think that's probably what the best we can do, is at least bend the cost curve for the next few years or decades, as opposed to try to flatten it. We'll talk about something about, later on, we'll talk about an example where the cost curve was actually flattened. This suggests that there's places to bend the cost curve. And some of these, granted, are American. I don't think fraud and abuse is a major concern in our country. Pricing is, there are elements of pricing in what we're doing in terms, and again, if you read, excuse me, some of Will's work about how technology is advanced and, excuse me, technology advanced, and yet some of the savings that are realized because of technology are not showing themselves up and are not dropping our prices. Prices are continuing. So there's an element of that in Canada. Administrative complexity is clearly not as an issue to the same extent in our country as it is in the United States. But all these up here, I suspect, it wouldn't be hard to find evidence to suggest that we deal with the same issues. Okay, so these are Berwick's projections of how they could try to address their sustainability question in the United States, which in some ways perhaps is even worse than ours. Okay, Michael, back to you.
So, as we've thought about it, and as we've looked at the literature, or are we jumping ahead? As we've looked at the literature, the questions of what we need to support the system, the health system, and to create a better functioning, more efficient system start to become clear in terms of what kinds of information systems do we need to have. And we've spent a long time talking about some of these categories. Those of you in the IT space will recognize these right away as being areas where we've sort of targeted for investments across the country. And these are big databases of clinical information. And most of this is just data about patients, very much kind of store and retrieve kind of concept. We put it in there for another clinician to be able to pull it out and look at it. What's clear is that by building all of this, we don't move the cost curve at all. We probably don't move the quality curve either. That this is necessary but not sufficient to make a meaningful difference in the way healthcare operates. In fact, it's some of these things that are clearly required to be able to change the operating efficiency and quality of the business. So a real focus on managing processes and making sure that the care process is actually delivered reliably, repeatedly, without mistakes, that relationships are facilitated and managed, relationships between patients and providers, and relationships between different providers. So especially this idea that the consumer, and I didn't, we debated what word to use here as to whether we should say patient or consumer, okay? Patient implies somebody who's really in active treatment. And really we're talking about something here that's actually more continuous, that there's a more continuous virtual, almost 7/24 accessibility between the individual and their most responsible care provider. Kind of the relationship that I have with my accountant, that I have with my lawyer. And on a Saturday, and I'm working on my financial books, I can email my accountant who happens to be in Edmonton, kind of a quirk of the way things evolved, but he's in Edmonton and I like him and he's very, responsive, and he flips back a comment to me the same day on a Saturday. And I want to have that relationship with my doctor. And there's absolutely no reason why I can't have that relationship with my doctor. So this issue of managing relationships, and of course, my doctor can't give me much informed advice unless they have access to some of this too. So there's relationships here. And then I want my doctor and my specialist to communicate effectively. Because it drives me crazy when the specialist tells me one thing and my GP tells me something else, and I want them to talk to each other and decide which of the two pieces of advice they want to give me collectively. Standard clinical protocols and enrollment. So the enrollment concept is, the whole idea that we would track somebody's status for a particular intervention or prevention or disease state management over time and make sure that they're getting everything that they can benefit from. That there would be exception handling when somebody falls off a protocol, and I shouldn't manually have to do a chart review in my office to figure that out. So if somebody misses their 5-year colonoscopy follow-up, I expect my computer to tell me that. And if we build all of this, none of that happens. Okay, we need more active process management systems, which we are starting now to see in Canada, but in some of the organizations we'll talk about in a few minutes. They've taken it to the nth degree, and I think we can start to see results that are truly transformative and something that I think is a bit of a beacon for us in terms of what we can do. And this continuous monitoring concept, it's a kind of an extension of the continuous communication. I want somebody to be able to monitor my blood pressure and my pacemaker, operation on a 7/24 basis. And I want them to call me if I'm having extra, premature beats or whatever. I want them to give me a call and tell me about that. I don't want to wait until I actually experience symptoms before somebody does something about that. So this is a major shift in the way we think about information systems, the way we design systems. When you think about who best should do this, very different answer from who best should do this. So we've really got some organizational thinking to do about how to be able to make this transition. And I think that's one of the themes that Dennis will now pick up on is if we do the IT part all by itself, we're not going to achieve any kind of significant improvement. We've got to do the IT plus some major organizational changes in the way we organize the health system in order to achieve the potential that I think we're trying to point to.
Okay. All right. One of the global organizations that frequently gets referred to, and justifiably so should be referred to, is the Veterans Administration in the United States. You're probably aware that that was the worst part of the absolute worst part of the American healthcare system in the 70s and 80s. And they reached a point of crisis to the point of almost deciding to disband the Veterans Administration in entirety and send the veterans scattered out throughout the healthcare system in the United States. So the decision was made that we've got to try to salvage it, and they salvaged it. And they turned that organization around over a period of about 10 years, so it became the gold standard for the rest of the American healthcare system. And they did it in a number of ways. It's been studied to death by a variety of independent organizations, including this particular Congressional Budget Office study of that organization. And they've documented some impressive statistics, which they continue to demonstrate. They are as effective as they were before, but their complexity level of healthcare has changed dramatically in the last 10 years, particularly around dealing with mental health. And many of the veterans coming back with serious mental health concerns, which is having quite an effect on their own system. But nonetheless, they were able to flatten the cost curve and are still running below the cost curve of the rest of the American healthcare system by quite a bit. And they were able to demonstrate that they could shut down acute care beds, expand primary care and community care extensively, and go through a period where they saw more patients, had less beds, and had fewer staff, and yet increased the quality of care. So how did they do that? Well, they did it through a variety of ways. Which one is that slide? Okay, yeah. The first part they did was, well, it's not number one on that, it's number two, is that they drove the agenda completely on a quality agenda. They said that we're going to change the quality of health care that we're offering our veterans, and that became their mantra, and that became their driving force. Secondly, they did some significant reorganization. They decentralized, so to speak, the healthcare system within the Veterans Administration, which is 150 medical health centers scattered all around the United States, and developed a new relationship between the central control in Washington and the regional, local delivery control in all of their medical health centers. And thirdly, and perhaps most relevant to our discussions today, they implemented information technology. And they implemented it in two particular ways. They had and they reinforced the most advanced clinical information system to support clinicians in day-to-day care. So they were one of the first organizations to go virtually paperless. They were one of the first organizations to put in clinical decision support. They were one of the first to put in clinical protocols. So that was the clinical information system component for day-to-day care. They also were one of the first to introduce a data warehouse in healthcare, and were able to collect the data that was coming out of their clinical information system and amass the evidence, which they would then study and look at their own evidence and say, okay, we've studied how healthcare is being delivered, and we find that the way the clinicians in Missouri are treating this particular kind of condition is generating the best outcomes. Therefore, we will take that knowledge and we will go back to our clinical information system and we will modify our protocols. So now the default protocol for this particular condition is the way they do it in Missouri. Allowed to go outside that protocol if you wish, but this will become our standard protocol because it's providing the best outcomes. So they were able to do that because of the data warehouse and the analytics capability that they also introduced and were one of the leaders. Their findings, this just then summarizes, I guess in some ways, some of the things I've already said in terms of what their clinical information system and their data warehouse those two elements, which are important, was able to do in terms of providing them the kind of day-to-day support in improving care. They were one of the first to do CPOE. I mean, there was a study, quite famous study done by Chaudhry about, goes back now 8 or 9 years. And they looked at all the evidence and to see where is technology helping us in healthcare. And after doing this quite thorough review, they found that, it was an American study, that there were only 4 organizations that were accounting for 80% of the evidence that the benefits were beginning to occur. And not surprisingly, the VA was one of those organizations. And also not surprisingly, but a little bit discouragingly, they were found that in that study that the organizations that were producing the benefits had all been at it for at least 10 years before they started seeing some benefits, both in terms of quality and in terms of actual financial benefits as well. And that came as a bit of a surprise. And the biggest surprise came at that time was that all of those systems from those 4 organizations were all homegrown, home-developed systems. And it wasn't until later, until more recently, in the last 5 or 6 years, we're starting to see some evidence now that there are some benefits beginning to occur, and they're beginning to occur with also provider systems as opposed to homegrown systems. But the VA is well...
Just to interrupt, Dennis. It's interesting that that impact study in Europe a couple of years ago also showed that significant time lag. It took 5 or 6 years before there was any clear economic advantage in terms of more cost-effective care delivery from the implementation.
The HIMSS analytics, which I'm sure many of you are familiar with, which measures the state of information technology in hospitals, particularly in hospitals, although they're starting to move in ambulatory care now, but particularly in hospitals. Their data suggests to them, too, that return on investments don't begin to appear until an organization gets to level 6, okay, which is second highest from the level of their model. And it takes a while to get there, and it takes a while, even once they're there, before they begin to see the financial benefits. Quality benefits can and do start to appear more quickly than that. Okay, Michael, that's our data from the States. Yeah.
The other thing, just to add to the VA story, a few years ago, Ken Kaiser was here. I mean, he's made many trips to Canada, but Ken was one of the earlier drivers of the VA transformation. I think he was at the helm for 3 of those early years.
Critical start.
Yeah. And Ken's a physician, and so, you know, I asked Ken, what was the reaction of the physicians in making these kinds of changes and sort of taking best practice from Missouri and making it, you know, kind of a national mandate? And he said, I didn't really have that much trouble with the physicians. The physicians, you know, it wasn't that bad. And I said, well, like, you know, what do you mean? Like, what did you experience? And he said, well, I only lost about 10% of the physicians during that process. And, you know, he thought that was, okay, that's the way it is. You know, change requires dislocation. He also personally handpicked the leadership of every regional division of the VA across the country. I think that was about 150 appointments. He changed every leader in the organization. So when we talk about change, it is not necessarily something that can be done in a harmonious and consensual way. You know, once benchmarks are established, then there is a relentless pursuit of those benchmarks, regardless of you know, what needs to be done to achieve them. So I often reflect when you read things like this, it's always so almost sterilized that it all looks like a very nice story and gee, why don't we all do that too? But in fact, you know, change agents who have led some of these things, like the Berwicks of the world, survive very short periods and are usually vilified and then extruded from the system because they represent such a revolutionary sort of process. So Graham, I think if we negotiate a good deal with the OMA and we only lose about 10% of Ontario's physicians, I think there's your benchmark. And Dennis, I think the first slide in that, like just looking at some of these markers over a 5-year period with the VA, 10,000 fewer employees, 104% increase in patients treated, okay, and the same cost per patient day over that period of time while the rest of the industry increased dramatically. I mean, just a very different sort of result. This is another sort of organizational piece that we decided to pull out just when talking about primary care. We've all been struggling with how to get doctors in primary care to use electronic medical records. One of the things that's very clear is that if you have physicians practicing in a group, it is much easier to move them to an electronic system than if they're practicing as solo physicians. I once remember talking to a group of physicians about electronic medical records and trying to explain the idea of economies of scale, and that information systems show strong economies of scale. And some of the benefits of an electronic medical record is that it allows you to practice as a group and be able to do 7x24 or even extended hours coverage without impacting your lifestyle too much because you share the work with a whole group of physicians. And one of the physicians put up his hand and he said, "So what are you telling me? I've got to restructure my practice to suit information technology?" And everybody kind of laughed. And actually, yeah, that's what I'm saying. That's what you have to do. And that's what every other industry has done. Banks and airlines and all the rest of the industries don't operate the same way as they did prior to information technology being introduced. So we need to introduce into our IT dialogue more than just a debate about architecture of systems and a debate about standards and all those kinds of issues, and talk about how we need to optimally organize our healthcare system to be able to take advantage of these technologies. And what's very clear, particularly in Ontario, is that we are not well organized as a healthcare system to get advantage from IT. Now, what you see here in looking at physician practices and the character of physician practices in the United States, which is moving very rapidly to electronic medical records because of the incentives that were part of the ARA Act and the High-Tech Act and et cetera, is that the solo practice, the independent practice is on the wane. And there's a move to more organized and owned practices, owned by hospitals.
That's right.
Owned by corporate entities, but they are organized into larger groups. And it's interesting, the terminology they use here is physicians versus truly independent physicians. And you can see, the percentage that are, quote, independent dropping over time. I found this interesting. AMA is involved. I mean, truly independent actually has a positive connotation to it. Like, it's almost like they're sad that this is occurring. I read this and I look at it as, unconnected physicians who are isolated from having to provide high quality care. So I view this as being a very positive trend. So I find it funny and to look at the kind of the terminology and the way it's depicted. But I don't think that this was meant to depict this, but the way I interpret this is that this is a move toward an organizational structure that can be more responsive to patients and customers and can get more benefit from what information technology has to offer. Now, this slide I think we've all probably seen. I hope everyone has seen, but it's worth looking at again. 2009 Commonwealth Fund survey of primary care physicians. This is a little bit higher bar than just EMR adoption. We don't do well on EMR adoption, but this is 9 of 14 key clinical IT functions being in place. They're listed here. So it's more than just having an EMR. It's also, some process elements, guidelines, alerts, reminders for preventive follow-up care, etc. And you can see Canada's dead last, with a very small percentage of physicians saying that they do at least 9 of these 14 things. There's a new survey that's coming out. Dennis, you were saying that you've reviewed it, sort of pre-press, so you may want to comment on that.
The 2012 survey will probably be going out next month. I was asked to look at the questions and the methodology, and I made a few suggestions on how they could change a few things. So then they're also going to add some countries, and they're going to expand this data in terms of characteristics a bit more. What's interesting is, from my experience, I'm trying to say where will we sit in 2012? So when the data gets published, probably in this fall, from the survey that will be done, I think they're shooting for May or June to do the actual survey where we sit. So working with some of my international colleagues, I'm predicting that we will be hopefully in the 40% range. We are definitely making some progress. There's no doubt that we are slowly catching up. Unfortunately, almost everyone there will be significantly higher than where they are, although these are all pretty high already, but these, and I'm predicting, and some of us are thinking now we're going to set up a pool and we're going to throw $20 into them and to see who's going to be the closest. I'm predicting that we will be up around 40, but that will be second last. And that the only country that will be behind us will be France. They will probably have not progressed as high as we will. So they will be here at about 40. France and Germany might also be, I'm predicting that Germany, Canada, and France will be at the bottom 3 of these countries. The Americans will jump up. They'll definitely jump up. And now this, Norway, there's something wrong with the data, because I don't know why Norway's there, because Norway is a lot more advanced in terms of primary care than this data suggests. So something went wrong there, and I'm not sure what, because Norway should be up here.
Where is Japan and Switzerland?
Well, we don't know Japan and Switzerland. I can't comment on Japan. I haven't seen any data about Japan, and I'm not sure where they would sit. So Switzerland, if I recall the European data on Switzerland, because there's similar data available of this nature, which is a bit older now, it's 2007, and they are now going to be doing another 2012 European study of this nature, and again, that'll be coming out towards the end of this year. If I recall, Switzerland's sort of middle of the pack, but I'd have to double check that because I'm just going from my memory. But Switzerland is definitely not, I mean, the leading countries are by far the Scandinavian countries. And the UK is there they're up in there as well. Italy, Netherlands, Sweden, I would suspect Sweden will move up because they're making some advances, particularly knee prescribing. And Italy and Netherlands, I think, will move the less. So I would put Switzerland somewhere in here, but I can't say that for sure. Okay, in the interest of time, we better move on. New Zealand is a fascinating story, and it's a story that is also worth studying because they have a lot of lessons that we can learn. New Zealand, along with Denmark, are probably the two most interconnected, where the healthcare system is connected to countries in the world as countries, as whole countries. We have regions within countries that are very connected, okay, such as Lombardia in northern Italy, Andalusia, and Catalonia, even to a certain extent Madrid in Spain, but that's not the whole country. That's regions or like provinces. New Zealand and Denmark are countries, and the whole country is connected. And they have similar stories as to why they've succeeded. One of them is a very heavy devotion to standards and to have established everything on some very tight standards. And also, they've had the good fortune of having a mechanism to stimulate change. And one of the mechanisms to stimulate change in New Zealand ties back to our primary care theme, was that the government issued a dictum that said we shall do primary care differently in our country. And they basically said, this goes back about 10 years, they said to the physicians, you will begin to work in group practices. No more solo physicians. And in New Zealand's case, they gave the physicians the opportunity to form their own practices. They said, I think they set a minimum, I can't remember what the minimum was, minimum number of physicians to work in the practice. And they gave them a year or two to form their own organizations, their own group practices, and they then proceeded, and that was a very heavy stimulus to them beginning to introduce electronic medical records, in part because of the economy of scale type of issue that Michael said. The other data about economies of scale is that the American data is very, very clear that the use of electronic technology in physicians' offices is much, much higher in larger group practices than it is even in small group practices, let alone in solo practices. But the other aspect of New Zealand, and just moving on, is that they also had what I refer to as a single unifying organization. My work internationally has identified what I think are the success factors to being successful in terms of effective use of information technology in healthcare. And one of them is there seems to be, in those organizations and jurisdictions that are more advanced, a unifying organization of some kind. And in New Zealand, it happens to be a private company that provides the integrated network capability for the whole country. In Denmark, there's an organization called Medcom, which also provides that integrated network capability, including setting the standards, the monitoring, the compliance, and all those things. That's a pseudo-government agency, arm's length from the federal government, whereas the organization in New Zealand happens to be a private company. In other success stories, it's the Department of Health of that region or that country. So that's an aspect that, and of course New Zealand and Denmark, basically 100% utilization of technology, but particularly by their primary care physicians, okay? And virtually paperless medical offices. Okay, Michael, let's get going here.
So just a couple of other tidbits to add in the primary care space. This article came out in the New England Journal just recently, which showed that use of EMRs actually improves the quality of care. Particularly chronic disease management, is better managed, and as a result, requirements for acute care services go down. So this is an interesting article you can see, just came out in September. And I've just picked one of the graphs showing for some of the key risk factors for people with diabetes, and showing the difference between, this keeps advancing by itself, the difference between practices that have an electronic health record and those that are paper-based, significant differences in everything except body mass index, which I thought was interesting. Some things are not amenable to electronic influences. So it's actually an interesting study. It's worth digging out to just have a look at the effect. And of course, particularly looking at composite indicators, the combination of those indicators really being really the risk factor for cardiovascular disease in this case. There's multiplicative effects of these different items, and you can see really a substantial improvement. We're beginning to see, and I say just beginning to see, robust studies that are showing quality of care improvements as a result of using electronic systems. So let's just sum up with this slide, and then we'll take some questions. So, what are some of the things that need to be in place to get value from an IT investment? So I think we've touched on most of these. Whoops. So economies of scale, we've talked about that quite a bit. The actual use of the information to analyze practice, feed it back to clinicians, feed it back to managers of the system. And I'll jump down to incentives, and to drive incentives so that the incentives are actually aligned with the patient's interest. Relentless and merciless focus on achieving performance benchmarks. So this is different from reporting. Reporting is not relentless, nor is it merciless. Okay? This is saying we're going to hit the benchmark, and we're going to do whatever it takes to get there. This is what happens in any kind of environment where the customer is in control, because the customer is merciless. Okay? Ask RIM if the customer is merciless. Okay? The best service, the best product wins. Okay? And we actually don't really do that. We report 10% and 20% differences in performance, and we all comment on it, and we move on. And what we need to do is say, we're making a choice, this is the benchmark performance that we require, and everybody will drive to that performance. Protocol management, decision support, we've talked about that. The key here is that we need a health system that is equally effective at managing chronic disease as we have automobile dealerships reminding us when we need to do oil changes and other preventive maintenance. Linda, we were talking about colon cancer screening before. We know that it's a huge cause of preventable death in Ontario. If we had a system that was as good as the auto dealers have of telling me when it's time to change the oil, we'd be in great shape. Deaths in this province would drop. So again, being active, okay, decision support sounds actually like a big deal, but it's actually just issuing reminders to people that, hey, you're overdue for this intervention that we know that you would benefit from. Incentives based on value, not volume. That one is there for Graham. value. And that in the 10% comment. So integrated care, I think we've talked about a fair bit. It's hard to process things unless the various parts of the system are connected. The game, my view is that the sustainability game will be won and lost in the primary care environment. Because that is where, if we do well, we can manage demand for acute care services. And finally, we debated whether to put this in because we didn't spend much time talking about it. But an observation that I would postulate, or a hypothesis that I would postulate, is that any industry that has transformed in a major way as a result of IT incorporates a huge amount of the customer providing themselves with self-service. I mean, you think about any industry that you interact with on a regular basis, self-service is a major part of it. So bringing the customer, bringing the patient more actively into the game is critical. And then we put this on the bottom because we don't know if this is the whole list. So, this is very much a work and an experiment in progress. But we've watched the the literature and what's happened in other countries, and I think these are some of the themes that are emerging in terms of getting value, both from a quality perspective and a cost effectiveness perspective.
Just a closing note in terms of integrated care, we made reference to the Veterans Administration. There are other organizations in the United States. The United States is a fascinating dichotomy because it has one of the worst healthcare systems in the world. As a nation, it ranks quite low, but yet it has these pockets of excellence. And there are other organizations now beginning to rival the VA in terms of quality, in terms of effectiveness. Kaiser Permanente, Group Health, Geisinger, Intermountain Healthcare, Cleveland Clinic. There are some that are there providing high quality care and are controlling their costs. So there are solutions out there, but most of those are also integrated care organizations where the full spectrum of care is being covered, and that's why integrated care is so important. Stop there.
So Graham, I'll send a copy of this the minute it's up. As soon as our techies are done, I'll send it straight to your adversaries. Thank you. Questions? 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 Here, let me give you the mic. Let me give you the mic.
In the U.S., the HMOs provide a typist in the room with the primary practitioner together with a nurse, and this helps efficiency. Would the state in Canada do the same?
Well, I guess first of all, I would. My first thought that comes in response to that is that would in part, I think, be a decision by individual practices if they chose that approach. What that question triggered was an indirect answer was that we gave the New Zealand example, and the organizations that were created, the group practices that were created across the country, they formed themselves into an umbrella organization called IPO, Independent Practitioner Organization. And I wasn't here, but apparently last year, a representative of the IPOs came and gave a talk. It was either here or in Montreal, one of the two places, and made reference to the fact that one of the changes to the way they delivered care was that the ratio of physician to nurse in these IPOs was 1-to-1. So that for every physician, there was a nurse or a nurse practitioner. And they were obviously changing their delivery mechanisms. And apparently, someone was heard to say quite loudly, never going to happen here. So that's just a reaction to your question as to whether the typists. I've been to the Kaiser's sites, and I've been to VA sites and whatnot, and in their primary care portions. And I must admit, I don't remember seeing any typists. So I'm not sure which HMOs were being referred to. And one wonders whether or not that typist's primary job was to capture the data and get it timely and correctly from a billing purpose point of view. I don't know. I can't answer that. Michael?
In Saginaw, this was in the room to type down the reports from the doctor.
Yeah, and I mean, a couple of other reactions. First of all, I don't know that that's more efficient. Secondly, I'm not sure why the doctor and nurse would be in the room at the same time. And the other reflection I would have is, why didn't they get the patient to document some of that themselves? So it just raises a lot of questions in the absence of an organizational context and actually seeing quality results. It's hard to answer.
So send me the reference, Alex, and we'll post it. Thank you very much. I'm curious that you use the word typist. You don't hear that very often anymore. Way over here. I give you the mic because that way we record it.
With regard to group practice of primary care physicians, does that affect at all the distribution of physicians geographically within a region? And does it at all affect adopting practice models such as family health teams?
Well, I'll answer that again, just drawing on my international experience, and that definitely has a huge impact on geographical distribution. Another region or jurisdiction that chose to reform primary health care similarly to New Zealand was Andalusia in southern Spain. Large region with Seville as its center, 9 million people in that region. They decided that they wanted to reform primary care and made the same decision, no more solo practices. But in their case, they were a little more autocratic. They said, we're going to open up 1,500 community health centers in this region, and you, Dr. So-and-so, will work in this one. And they literally assigned them. So I'm sure in some cases there was some disruption where a primary care physician might have been in one community and probably had to move so many kilometers to be part now of this primary health center, community health center, which included dietitians, physiotherapists, in some cases pediatricians, and nurse practitioners. So yes, there was a disruption. I'm sure there was, and I'm sure there were some disruptions in New Zealand as well.
Well, thanks for the informative talk. First of all, my question is related to the private sector. So what do you think the role of the private sector would be or should be in rolling out the health information technology initiatives in the coming few years?
Well, that's a general question. I think there's a variety of ways that we're going to see the private sector as a player. First of all, most of the innovation in this space comes from the private sector. There are exceptions to that, of course, but most of the software vendors and most of the components and hardware and substrate of IT is coming from the private sector. So clearly, in a close relationship with the private sector is going to be essential in making this successful. One of the observations that I would make when we go back to the early slides is that we're moving into an era of really significant cost constraint and capital for investment is going to be hard to find. I think we've also seen a number of projects that have been very successful, and we've seen projects that haven't been so successful. We've also looked at some of the data that suggests that real financial benefits from some of these investments take years to develop. There's been studies in the US, in Europe, that suggest 5 and 6 years is kind of the time course before you see a benefit. which of course is longer than the electoral cycle, which makes it tough from a government investment perspective to make those sorts of investments. So I think we're going to see a move to an era of more innovative ways of financing some of the build out of the infrastructure around IT, where it's capitalized by the private sector, where there's risk taken by the private sector. And in fact, the old models of capitalizing a big project build will be replaced more by software as a service kind of subscription models or transaction models, where the public sector healthcare system pays only for a transaction that provides value at that moment. And rather than saying we need $100 million to build out a platform that may or may not work, that we actually give mandates to various organizations who will then have the ability to charge a transaction fee. And we've seen that kind of model in other parts of government IT. Probably in Ontario, the land registry model, which is driven by TerraNet, is a great example of that, where there was a 10-year digitization of land registry information, and we've moved to a situation where lawyers and real estate agents and mortgage brokers can get information about a property from their desktop in seconds for a few dollars, compared to the 10-day process it used to take, where clerks would dig into filing cabinets trying to pull out information. But that was all privately funded. And a couple of years ago, I think it was 2 years ago, the government announced an extension of the franchise that they gave to, the exclusive franchise that they gave to TerraNet for the land registry service in the province of Ontario. And it was a 50-year extension. And for that right, TerraNet paid the Ontario government $1 billion. So we could be in a situation at some point in the not too distant future where the mandates for running eHealth infrastructure are actually auctioned off to paying private sector players. Now, of course, there's all the challenges of privacy and ownership of the data and all of those things that make it a little bit more complicated than land registry. But I think given the capital constraints that we're going to be laboring under and the cost constraints, and on the other hand, the need for technology to be able to continue to have, a health system that's on par with those in the world, we're going to have to look at very innovative financing models to be able to achieve that.
So both the slides and the presentation will be up on our website. Look for it there, and with their permission, if you want their email addresses, write me, and I could share that with you. Dennis, thanks for coming all the way from Victoria. Much appreciated. Michael, thank you for the idea and putting this together. We'll see if they appreciate it. Thank you for coming to Breakfast for the Chiefs.